to a case of chemical injury, and I think we all know that this basically is one of the very few true ophthalmic emergencies that we see, which can be potentially devastating, that can lead to severe ocular morbidity, and it affects any age group, mostly young adults. And the severity of the chemical injury depends on the toxic agent, the time of contact, the area of contact, the intraocular penetration, and the presence of any other additional mechanisms of injury, such as thermal or mechanical. Between alkali and acids, the alkali injuries cause more damage to the eye because they tend to penetrate inside the eye more, and the most serious alkali injuries are caused by ammonia and sodium hydroxide. And in India, we have this peculiar injury due to the tuna packets, which is caused by calcium hydroxide, which is a very, very severe form of alkali injury that occurs to the eye. Acids also can cause a lot of damage to the ocular surface, and the most common is sulfuric acid, which also causes a lot of additional thermal damage, especially when it occurs because of these car battery explosions. I think when we talk about chemical injuries, it's important to know what stage of the injury you are examining or looking at the patient. So when it's within 2 weeks to 1 month of onset of injury is what we call as the acute stage, when the eye is still inflamed and when you have an epithelial defect. And the chronic stage, as you can see on the right side, is beyond 1 month of onset of injury, when the eye is quiet and the surface is epithelialized, whether it's epithelialized with conjunctival cells because of the limbal stem cell deficiency, or whether there are adequate limbal cells to allow epithelialization with the cornea. Whatever might be the situation, as far as the surface is epithelialized, it's the chronic stage beyond 1 month. And sometimes you might have these semi-acute cases where the shift to the chronic stage has not occurred even beyond 1 month of onset, and you have persistent inflammation and a persistent epithelial defect. So it's important to understand a little bit of the pathophysiology, that the problems that occur in a chemical injury when the chemical comes into contact with the ocular surface is because the epithelium has been lost, both the corneal as well as the conjunctival, because of which you have access of the inflammatory mediators to the underlying stroma, which is basically what leads to the haze, the stromal haze and the ground glass appearance. And ultimately, over the next few days, it can lead to a stromal melt. And if the circumstances permit, then you can have a secondary infection in these eyes because you don't have an epithelial cover. If you need the epithelium to regenerate, you need stem cells both corneal as well as conjunctival, and because the chemical damages both your limbal stem cells as well as the conjunctival stem cells, which are located at the fornix probably, the regenerative capacity is compromised. You have a loss of the limbal barrier, and in addition to these two pathologies that are occurring in the ocular surface, you can also have damage to the vessels, which leads to ischemia, which further impedes the re-epithelialization process. So understanding this, we define the goals in management of acute chemical injury, which are basically to get rid of any residual chemical in the eye so that it does not continue to damage the ocular surface. You try and retain or regain the function of stem cells if possible. You retain a relatively clear corneal stroma as much as possible, for which you need to get back the epithelial cover as quickly as possible. You try to overcome the phoneal shortening because nature's attempt to salvage the anatomical integrity of the globe is to quickly shut down the ocular surface, which is why you see the significant symplepharon. And of course, you have the raw surfaces on both the palpebral as well as the ocular surface. And you want to, under every cost, prevent sight-threatening complications. And to achieve all this, you need to have a very quick epithelialization of the ocular surface.